is a program of innovative orthopedic networking, e-learning, education, and research that was designed to fill the gap left by the absence of face-to-face meetings, courses, and other activities during the 2020 coronavirus pandemic. But Pioneer has become so much more than this in the intervening year. Pioneer is a virtual, but also very real community of like-minded orthopedists striving to help not only themselves, but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's Pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Good morning, good afternoon, good evening, ladies and gentlemen. Welcome to the SICOT Pioneer webinar series. I'm Dr. Margaret Falk from Hong Kong, the chair of the SICOT Education Academy. Before introducing today's chair and faculty, I would like to share some background of the SICOT Pioneer initiative. SICOT Pioneer is part of the SICOT Education virtual platform, which launched in June 2020. Since its inception, we have organized over 91 webinars and 6 tete-a-tete sessions. To date, the platform has garnered over 46,000 live views and nearly 77,000 on-demand views. We are also proud to have a Pioneer fan club of over 12,000 members. If you'd like to explore our previous webinars and other education activities, please visit the SICOT website at www.sicot.org. We encourage you to join as a member to access these resources on demand. Today's webinar is organized by our SICOT Education Committee, which is led by Dr. Saseendar Shanmugasundaram. It is co-organized with the British Orthopaedic Sports Trauma Association, which is also called BOSTAA. It is about the global view of orthopedic education in this era. Our moderators are Professor Mohamed Imam, who is the consultant of orthopedic surgeons and clinical lead for trauma surgeries, Rowley Bristol Orthopaedic Unit of Ashford and St. Peter's Hospital, who's Chelsea, UK. He's also a member of the SICOT Education Committee member. Joining him is Dr. Gowreeson, who is a consultant of hip and knee surgeons, Concord University Hospital, London, UK, and she's a member of the BOSTAA. So without further ado, I'd like now to hand over to our moderators, Mohamed and Saseendar, to begin the sessions. Thank you.
Thank you very much, Margaret. It's a pleasure to be here. Dear colleagues, I think this is a very interesting webinar, and today's theme is Orthopaedics in the Digital Era, AI at the Frontiers of Surgery, Education and Global Impact. I have the pleasure of co-moderating this session with Mr. Sarkar Rada under the chairmanship of Professor Saseendar Shanmugasundaram from India, and we have eminent global speakers from all around the world. Each talk will be 8 minutes, followed by 2 minutes of questions and answers. Please post questions in the Q&A panel at any time. If you'd like to speak, raise your virtual hand if needed. Mr. Sarkar Radal, do you want to?
Thank you very much. Thank you, Chair, and thank you, Organizer. Thanks, Prof. Imam. I think you've mentioned everything that can happen today. So looking forward to hear the presenters and, as you mentioned, the question as well.
Perfect. So our first speaker is Professor Rowena Johnson, consultant radiologist and a data scientist and one of the pioneers of artificial intelligence in radiology, and we're very happy that she will explore how machine learning models are redefining musculoskeletal imaging from first presentation to triage. Up to you, Rowena, please.
Hello, I'm Rowena Johnson and I'm a musculoskeletal radiologist, and I'd like to thank the organisers for the kind invitation to speak today. I'll be talking to you about smart scans and sharp eyes, so AI in orthopaedic diagnostics. So the objectives of this talk are that we're going to talk about the rise of AI in medical imaging, the integration of AI into the clinical workflow. We'll examine the benefits and the limitations of this, and also discuss the regulations. So what's great about AI in imaging? So we have an increasing volume of scans and increasing complexity, and what we need is rapid and accurate diagnostics. AI has the potential to augment radiologist expertise and also improve patient outcomes and workflow efficiency. So RSNA, the Radiological Society of North America, hosts a conference every year in November, and it's the largest conference of any type in the world. So there's more than 40,000 radiologists there, which probably explains why your scans are a bit slow being reported at that time. It's held in Chicago every year. The last one had over 50 scientific papers, more than 1,400 posters, 1,600 educational exhibits, and more than 300 courses. So it's massive. And a survey of their attendees at the last RSNA meeting showed that AI was consistently the most popular interest in topic that radiologists want to learn more about. The Stanford 2025 AI Index report, which is a really interesting report, shows that the number of FDA-approved AI-enabled medical devices just continues to rise dramatically. So in 2015, they had only 6 devices approved, and by 2023, they've had 223 devices approved. And you can see on that graph just how sharp the rise is. Medical AI ethics publications are also increasing. So between 2020 and 2024, it's quadrupled just in that period of time. So as radiologists, main thing that people think about when they think of AI in imaging is that going to replace the radiologist? And there's that fear factor, right? That Hollywood, the robots are rising, but it's very overhyped. You get these headlines and that's not really the reality. So AI is that pattern matcher. It augments what we does, but it doesn't replace what the radiologist does. So why would AI steal our jobs? So as a radiologist, my family don't quite understand what I do, and they're not quite convinced that a radiologist is actually a doctor. And what they say to me is it's going to report 1,000 scans whilst you're sipping your coffee. It's not going to take any days off. The orthopod's going to be delighted because no one's ever going to reject a scan request that they have. And AI is also going to memorize every rare disease. Why are we still indispensable? So we have empathy and communication with our fellow clinicians and with our patients. Hopefully you think that. We undertake interventional procedures, so particularly across different specialties. So vascular, but MSK is huge for intervention as well. We understand the patient history and we understand the clinical nuances, so something that AI can't quite catch up with. And we do occasionally have those aha diagnostic moments when we can get things, put all sorts of weird and wonderful things together. So radiologist and AI is the dream team. So the AI will flag up anomalies for us to review. It will allow us to focus on complex cases and spend more time on patient care. And what it does is it merges speed with clinical expertise. So just as a case study, so this is a broken heart scan. So this is an acute scan done at 1 a.m. in the morning. AI spits out saying no fracture in a trauma patient. Radiologist spots the pericardial effusion. Lesson learned, heart beyond pixels. So AI is our sidekick, it's not a replacement. What we need to do is embrace and upskill it, and human insight will always win. But as radiologists, we have to have a seat at the table or risk being part of the menu. And what we have in terms of current imaging challenges is we have a high variability in image interpretation, subtle lesions and occult fractures. We have time-consuming measurements and planning, and we have both inter and intra-observer variability. And AI certainly has a role to play with this. So if you think about this with osteoarthritis and the grading on X-ray and MRI, it can give us better information in terms of quantitative cartilage assessment, monitoring disease progression, and standardizing scoring systems. If we look at further examples, such as in alignment and planning, we can give us automated limb alignment measurements, preoperative templating and 3D modeling, custom implant design, and enhanced precision and deformity correction. Certain things it can pick up, so your fractures, your osteophyte, your bone lesions, definitely helpful for bone mineral density, joint space measurements. And in terms of workflow optimization, that's why it's particularly helpful for us. So automated triage, so your most urgent scans get pulled to the top of the list. It can draft reports, and it's also quality control, so that's second check. The benefit for the surgeon is you get a faster preliminary report in acute settings, so such as in major trauma. You have your quantitative metrics for your surgical planning, and for the radiologist, it takes out the mundane tasks that we may not necessarily want to do, and it's just that second reader safety net. So radiology in particular lends itself well to AI because we have such a large availability of data imaging sets across the world. All our data is acquired in the same format in DICOM, and pretty much across the whole world, the vast majority of it is electronic. So this was a survey looking at radiographers, radiologists and students in terms of their knowledge of and attitude to education. The vast majority of respondents were radiographers, but it showed that up to 30% of people were using AI. I think it was 28% were using AI in their practice, but only 10% had formal education in it. So what do we need to be concerned about with that rapid rise of AI? So it's just so rapidly increasing, but it's not necessarily replicable. It's a high risk, high reward environment. So we have a significant potential for improved patient care, but there's learning in progress, and this can harm small subgroups or certain demographics as the data may not be generalizable. And it's essentially learning on the job. So some of the understanding of the limitations are learned during deployment, and what it needs to do to be sustainable is it has to demonstrate real value. So the challenges we have as radiologists are integrating it into our existing workflows in PACS and RIS, collaborating with IT teams for compatibility. So often it's IT that's our rate limiting step for getting it in. And during the calibration and implementation period, it needs time to adjust to the radiology workflow, needs time for us to address any technical issues. We also need to understand the adaptive algorithms, which can change performance, and we need an agile and flexible response to challenges and integration. When the evaluation, we need it to be rapidly evaluated post-deployment. We have concerns with our trainees. They claim that, which is understandable, that some of the easy scans don't get seen to them because they're picked up by AI. And you also need to assess if your organization is ready for it. Does it actually have the capacity to take it on? And that for us is, just our radiology workflow, but also the culture of the department, the staffing, and you need collaboration from the stakeholders. So the National AI Strategy set a 10-year vision to make the UK a global leader in trustworthy AI, and it was committed to the most trusted and pro-innovation system of AI governance in the world. So that's what the UK has adopted. So it's a pro-innovation, principles-based approach to AI regulation, and what it does is it builds largely on existing sectoral frameworks rather than creating a bespoke AI law. and implementing these principles. So there's no standalone AI regulator. That's important to understand. And the white paper confirms there are no current plans to bring in a new AI regulator. So what it does is it relies on existing bodies to embed oversight into their domains. So looking at the risk of AI and design proportionate interventions, and also monitor compliance and outcomes over time. And this is emphasizing a sectoral rather than a central regulator model. So each industry regulator, so the MHRA for medical devices, the FCA for financial devices, etc., will interpret and enforce these principles where AI risks arise. And these are examples for you all in the orthopedic world. So just to see what domain certain aspects of your work in AI would form under. So that you also need to be aware of the Data Protection Act. So all AI systems have to comply with data protection laws. The ICO has has a governance framework on AI to guide organizations on building compliant and auditable AI pipelines. And gov.uk also has an introduction to AI assurance. So with document and assurance, we have to maintain a thorough model risk assessment records, validation reports, and incident response plans to satisfy MHRA and the broader AI assurance framework. Always important to stay engaged in sandboxes. So these are controlled environments where AI systems can be deployed and tested and validated before they're released onto market. And that helps to encourage innovation whilst mitigating potential risks. So the key messages of my talk are that AI is a powerful adjunct, it's not a replacement. Successful integration hinges on validation, training, and governance. We need a collaborative approach with radiology, orthopedics, and IT, and ongoing research will expand capabilities and improve patient care. Thank you very much. If you'd like to get in touch with me, LinkedIn's the best way, but thank you very much for listening today.
Thank you very much, Rowena, for such a very comprehensive talk. Excellent insights and actually answering few of the main concerns, especially radiologists, pathologists, younger generations having, and it is an empowering tool. So I have one question for you, possibly, which is how far are we from a diagnose at triage pathways that reliably can reduce the time to MRI or CT scans? Are we there yet?
Thank you for the question. I think we're further ahead in terms of what we use. So chest X-ray AI kind of reporting for that is pretty well established. I think it's a good screening tool. So you're talking about from triage from like
Yes.
a musculoskeletal kind of big trauma to getting to MRI. I certainly think you can. I think with the right kind of clinical with an experienced, if it's the radiographer there who takes a report off an X-ray, I think we certainly are there in terms of progressing onto further imaging, like cross-sectional imaging. And what it does is it just speeds up that process.
Thank you. There are no other questions. Thank you very much.
Thank you.
Okay. Our next speaker, I don't think I need to introduce him. He is a very well-known figure in UK and abroad, Professor Imam. He's on the line. He's not just excellent trauma and orthopedic surgeon, he is also the member of educational committee of SICOT, and he's a professor of digital. His topic on blueprint of precision AI for preoperative planning, which is very relevant to our work. Prof, you can start.
Thank you very much, Mr. Brother. It's a pleasure to be here with everyone, and I'm going to go through over the coming few minutes. It's, as we've discussed earlier, it is a very important topic, and historically, as orthopedic surgeons, it was all about hands and our precision and what we feel or do with our hands. And now, in the younger generations, it is about technology, and possibly technology plays a very important role in what we do now. I believe the reality lies in between. You still need surgeons, like what Rowena mentioned in the last talk. Human touch will always be there, but also technology makes our life easier. Technology can ensure equality of healthcare we give to our patients. But in order to understand the future, we have to go through the past. And actually, our main achievement as humans has always been human intelligence. And that enabled us to introduce tools. And the more sophisticated the tools, the more sophisticated our civilization. And in the industrial revolution and industrial era, more machines were introduced, and that changed our societies. And it was in the 50s when Professor McCarthy coined the term AI. And now we live in the exascale era, where we have huge computers enabling us to undertake a quintillion operations per second. That's 1 and 18 zeros. And that we can use to make humanoid robots playing football, and we can actually use it in surgery. And we did a survey asking 500 respondents from 10 countries in orthopedics, and the majority are convinced that AI is the future. That was 2 years ago. I disagree with that. It is the present now. But rightly so, many were skeptic about ethics and governance, and hence one of the talks by one of the experts in that field, Ms. Turner, is going to be at the end of this webinar. So how does AI work? AI actually is like it is artificial intelligence, which is similar to human intelligence. And it is the first time in history that we delegate our best achievements to others. And in orthopedics, we tend to use 6 applications of the commonest 8 applications used in artificial intelligence in general. So as a surgeon, when I'm sitting in my clinic, seeing my patient, listing someone for surgery, I would like to anticipate outcomes, because we all have operated on patients that we think that actually non-operative option might have been a better option for them. Actually, we published on how AI can predict infections and how can be a game changer in prediction of infections. We had an SICOT model, SICOT grant, which enabled us to design a platform where when we see patients, we put inputs on what is about that patient based on huge amount of data sets, and that we can anticipate the outcome. And that's actually the first step in surgery. When you see someone, it starts from the clinic. Not only that, even an orthopedic surgeon can use AI to predict to diagnose the retinal images picked up in scans with a 99%. So AI can help on all aspects of surgery. First, we are at the up slope of AI technologies, and that will filter, and then we will reach a plateau in productivity. So it can also enable us to save time in what we do. We spoke about how AI can help with many of the challenges we face nowadays in early healthcare system. And we think that AI is the future of a more efficient, more productive healthcare system in any country. There are a lot of aspects AI is contributing to in surgery. First, you can actually do your surgical procedure, if it is a complex one, by using immersive reality and plan to what is expected. You can even make your trainee practice or how to do an approach, so that make the training process more smooth and slicker, and that can happen before surgery. Obviously, we are obsessed, and rightly so, with surgical planning, and AI can help with a lot of aspects in surgical planning, from planning and doing 3D models of complex procedures. On the right side, you can see that you can actually take fluoroscopic images without a radiographer being there, just me here in Davos controlling with a remote control. And with the right system, you can actually have an automated analysis of the pictures. So that intraoperatively, the model can tell you whether there are screws in the joint, the reduction angles, and other aspects. Not only that, AI can help you while you're operating, and that can range from having the images and the planning models in front of you while undertaking the procedure, which is the virtual reality aspect, and that is becoming very common nowadays. A lot of children are using this as their only tool. But the game changer, I think, especially in upper limb and trauma and different aspects, is augmented reality, where you actually register the planning on the patient in front of you. So on the left side, this is my dissection of a glenoid in a reverse shoulder replacement. On the right side, I've actually already planned the surgical procedures that I am undertaking and where the best alignment you can achieve. And it's like hanging a large mirror on a wall. You're not sure where are the pipes and where are the cables, but actually having the augmented reality, you can see which direction should I put my screws in to have the best purchase and avoid injury, which can ultimately enable us to undertake a smooth leg surgical procedure, which is safe and hypothetically can reduce the potential risks. Not only that, you can ask AI while you're scrubbed as a surgical chatbot helping you while in a surgical procedure. Obviously, if you're a patient, you would like your surgeon to know the anatomy and the technical steps. But if you have to ask one, it might be possible to ask the whole internet and reliable sources that can give you different bits of advice if needed. Now we still have dual operations, but it might not be available in complex procedures for everyone. And obviously, what people keep citing, robotics, which is also can be enabling technological advance in what we do. And with robots, they are not all the same. There are different levels of robots which we use when we are doing procedures. As I said earlier, AI is actually a digital tool. It is a tool in the hands of surgeons, radiologists, pathologists, and clinicians everywhere. And the robots and the tools can range from a hammer, which will do whatever you want to do with, to a more accurate surgical tool that enables you to undertake the procedure, to what the most advanced we have at the current time point is level 3, where you tell a robot what is needed, you agree the plan with the robot, and it hypothetically can do it way more accurate and can do it quicker as well. A lot of work is happening on how to advance robotics autonomy, but it can be variable. Not only that, we can, even if we see a patient who had surgery and you're not sure that it's working, then, or someone with a potential deformity or imbalance of muscles, AI can enable you to identify the problem and identify the best option for them. It can help you to analyze the surgical outcomes of your patients by understanding the pathology before or after surgery, have sensors which will predict the abnormality for you, and then as a surgeon, you can plan the best course of action for these patients. And there are a huge amount of work being going nowadays in that regard, especially with rehab after surgery. And actually, what is a game changer is symbiotic robotic prosthesis, which gives our amputees skills and function we couldn't even dream of many years ago. So, to summarize, we're not actually talking about a new thing. People are usually surprised when I tell them that I've developed interest in AI 10 years ago, because everyone thinks AI started with ChatGPT 2 years ago, which is not true. As I said, it is from the 50s. And the answer to that question is yes, because we use computers and smartphones and everything we do, and more we're dependent on technology, but we shouldn't forget our human touch. Thank you.
Thank you very much, Prof. Imam. As usual, very colorful, very informative.
Thank you.
We have started on sustainabilities and environmental friendly move. I probably think past decade has been quite more relevant. Now knowing these AIs are quite powerful, and it's basically cost a lot of our energies and electricity. And then how can we balance environment and the technology and innovation?
An excellent question. For everything that technology related, this is a major concern. And all these exascale computers doing quintillion operations, they need electricity. And there are few things we can do, because obviously carbon footprint, and we discuss that, and I personally also is interested in the sustainability bit, but smart grid forecasting and real-time balancing actually raise the penetration of wind and solar and cut losses. Having green sources of energy can always help, but it is a valid concern, and I don't have a very strong answer for it, because AI can be both sustainability multiplier and load, because it includes full life cycle, carbon accounting, etc. But if AI becomes more intelligent, we can ask computers to sort out the climate change problem. We can leverage the co-benefits, like initiatives which will cover resource efficiency with cost savings. So I think that it is also one of the things we have that we need to sort. An excellent question, definitely. And obviously governance, which I think is very important, matters, because we should embed ethical review, bias testing, environmental impact assessment in everything we do nowadays.
And my next one, I'm really interested in that excellent project you showed on the infection, when you gather all the information, and I've seen it. So that looks like in the secondary care, you will input all the data. And I think that is a wider issue within the UK. I feel there is almost disconnect between primary and secondary care, because we do the same. We basically repeat the steps which could have been done at the point of referral. My question to you, do you not think it's the time for us to start these projects at the first point of contact, which is primary care, to at least offload us in the secondary care and use the time to treat, as you do a lot of complicated stuff, to treat these patients and save those time to actually for us to do more complicated secondary care initiative?
That's a spot on. And actually, we are, both of us, based in the UK. I think actually there is a lot of duplication in research happening. In the UK, we claim we are the biggest employer in the world, but it's not true, because our hospitals are 10 miles apart, and we still cannot access things done in different hospitals. And, I was speaking to Vipin, who's also one of the eminent faculty here. We are undertaking a couple of similar projects at the same time. And that's actually the importance of having governance and more collaborative work in AI, because there is a term in artificial intelligence, which most of you know, but for the participants, called GIGO. If you have good garbage in, garbage out, a lot of what we do is based on data we have already. Obviously, that will improve when we start doing more prospective analysis and things like that, but definitely duplicate, especially, I'm not aware of any healthcare systems that is not under immense budget pressures. You go to any governmental hospital or any public hospital, you only hear the word cost savings, how we can reduce costs. And I think actually that's why I showed one of these papers we published. To reduce costs, actually AI can help a lot, obviously having the sustainability bit in regard, but also having platforms where you share all different studies and different bits is actually the same, or access to what was done for these patients, because it is a waste of time. If I'm a GP and I do a hip x-rays on the hip, send the patient to you, and you repeat x-rays again, unnecessary exposure to radiation, possibly the x-rays done by the GP 3 months ago or even 6 months ago are valid for you to decide what to do. So it is there is huge amount. I personally think there is a huge room for improvement, and and many of the AI scientists think that we can improve a lot of the communication and collaboration, which is 2 of the 6 C's I've mentioned, by empowering and adopting more intelligent technologies.
Last one, but very brief, because I'm mindful of timing. How, with your SICOT hat on, how this society can help, at least to support clinicians like yourself and others, and recommend integration between different hospitals, for example, NICE guideline just published a recommendation on AI. I can still see there's that disintegration going on between different trusts doing this stuff. What do you think the role of societies like SICOT and other societies?
It is obviously SICOT and all the international societies with a huge number of membership can help significantly by starting initiatives that will enable collaboration and introducing minds alike to do different studies. Possibly you have a big database where you work. I have data scientists where I work. Someone might have big data on rehab, and Professor Gupta has some data on different aspects, and then we have all these data, thousands. We use the data scientist from Professor Sallam's office. We have Professor Turner's governance hat, and then we can set up a collaborative that will lead to a sensible studies that can change the governance and actually how we practice things. And so I think definitely with big societies, with big memberships, can have a significant role in making things better.
Thank you. Thanks very much.
My pleasure. Thank you very much. I enjoyed the questions a lot as well. Thank you, everyone. So now our next talk is going to be by Miss Irrum Afzal, who I knew for a long time. She is one of the most active data scientists with a lot of hats on. I don't know how does she find the time to do all that. She will be telling us how can AI help in orthopedic education. Up to you, Irrum.
Great. Can you all see my screen?
Yes.
So thank you very much, Prof. Imam, for the invite to talk on this webinar. Thank you. So I'm going to talk about teaching the future AI in orthopedic education. So artificial intelligence, the start of a new era. We've been hearing lots about it. And like Prof. Imam mentioned in his talk, AI didn't start 2 years ago when ChatGPT came about, but it has been around for a long time, starting up in 1951 and then being coined in 1956. So the evolution continues, and now it's become a talking topic. And we see AI being used in many different ways in the early concepts at the Dartmouth conference, but it's also being used through like ChatGPT and multimodal AI functionalities. But within this talk, I'm going to talk about how AI can be used within education. So AI is routinely used in medicine, like we've heard, and it's also used within research and in clinical use. But this talk is particularly going to focus on education. So AI in orthopedic education is a topic which has been discussed quite extensively. And if you look at the literature, there are a few papers that highlight the uses and the way AI can be embraced within orthopedic education and training. And these are some of the papers that I recently found on PubMed, the recent literature. But how can AI work within education, and what are the frameworks of it? So AI can be used within like faculty training, having the student engagement, having mentors, having personalized learning, and also having being in place for like curriculum development. And then taking that into a more educational, within the format of orthopedic education, it can be used within surgical simulation. The trainees, the registrars can use it as part of adaptive learning, virtual simulations. But more importantly, it also offers the opportunity to provide the assessment and real-time feedback. So whilst it's being used for sort of radiology interpretation, it also gives you that ability to provide you with real-time assessment, real-time feedback that can then allow both the faculty and the trainers and the trainees to make adjustments in real time. So here are just some examples of how AI can be used, the different types of AI, so like the personalized learning that I've mentioned, the simulation, the predictive analysis, the natural language processing, how they can be used, the applications, and then also the examples. So this is a busy slide with a table with all different examples. But what I wanted to highlight is that all these have various different benefits. So they improve, the learner engagement, but they also are safe. They also enhance clinical decision making. But one of the things they also allow you to do is they allow you to have early intervention for those who are struggling. So if you're having any problems, it allows you to pick out the real-time feedback. And it allows you, because through natural language processing and conversational AI, chatbots and robots, it allows you to have that accessible 24-hour support. So ultimately, it saves time and reduces admin burden. And one of the types of AI is generative AI. And this is an example of how generative AI can be used within orthopedic education. So you have your prompt, you collect your data that's required for your project or for whatever you're using in order to do your outcome. And then you put the data in, you process it, you train the models, and then you have the responses in different formats. So you can have the responses through text, through imaging, through videos. And then this allows you to have different applications that can be used within orthopedic education. So it allows you to have the clinical-based learning, the clinical images, and it also allows you to have exam preparation for important exams in orthopedics, for example, in the UK, your MRCS exams or your FRCS. But AI also then allows you to, within education, there's so much literature out there. It allows you to condense that literature, provide literature reviews through using various different tools, and allows you to have the evidence-based medicine. And then it also provides you with education and training, so live performances and the simulation. So there's various different ways that AI can be adapted and put into practice within education. But with all the benefits, it also comes with its fair share of challenges. But with all those challenges, there are solutions. So there can be inaccuracies and false information or outdated information. So it's important that the models are regularly updated through real-time data of the current literature. There can be inconsistent outputs, but that's important on the amount of data you have and developing a standardized response. There can also be, and it's important to be wary of this, and this was mentioned in the earlier talks about privacy and copyright issues. Making sure that there's not unequal access, and also, making sure that with all of this and using AI, you're not academically dishonest. So there's plagiarism tools are in place to detect plagiarism when using AI tools. And also, ultimately, AI will make us all efficient, but it's important that we don't lose the human touch, but we also do not become over-reliant on AI and the way it thinks, because we still need to promote critical thinking. So it's important that throughout all of this, you don't become over-reliant on it. With anything, however it's used, whether it's used in a clinical format or in an educational format, it's important to make sure that information, consent are compliant. And the key considerations, like previously been discussed, to make sure that you have your GDPR, you have your cybersecurity in place, but also ultimately, however it's being used, is to make sure that there's human oversight. And then the ways to make sure that you can implement it within education effectively is to make sure that you have simplified explanations, you're clear, and your disclosures are clear. You appreciate the risks, and you also see the limitations. You always make sure that there's a human oversight, and then you're ultimately making sure that your whatever you're using it in, there's data privacy. So, like as discussed, AI won't take your jobs, but someone using AI will. Thank you very much, and thank you for the invite again.
No, thank you, and thank you very much for this lovely talk as well. It's excellent and comprehensive. So the question I have for you, Irrum, is, because in surgeries, we've always been fascinated about cadaveric training, and the dissections in cadavers. We've done actually the first immersive reality deanery teaching in shoulders and elbows a few months ago using virtual reality. But how can we balance that? I know you've mentioned it, but it's actually a question, because I think also in surgery, it's always a concern younger generations have.
Yeah, so I think the one way to implement that is through having using VR simulation. And I know it's not the same as having the cadaveric feel, because nothing will replace that cadaveric feel of actually doing on a real cadaver. But I think the way that it can be implemented is, and in the most realist way, is through virtual reality.
Yes. I think that's actually, it is definitely cheaper and it's easier to sort out, but still the tactile touch is not there yet. But that's the only thing I would say. So another question, last question, is do you see generative AI replacing conventional Viva and OSCE formats? I know you've touched it, but is that something you would, what are your thoughts on that?
I don't think it will ultimately replace it, but I think it will be used simultaneously. I think it will become, because people are more and more using it for like the FRCS exam preparations, and there was a paper that was used on that's been written on whether how ChatGPT answered questions and how a human answered the questions for an FRCS exam. And so it won't replace it, because it will require, but it will be. I think it will definitely be used simultaneously, and we'll definitely see more of it being used simultaneously.
Okay, lovely. Thank you. So that's it for the questions. Up to Mr. Rada.
Excellent. So our next speaker is Professor Asir Sallam from a beautiful Egypt, the land of ancient wonders, and pretty much.
Thank you very much.
He's an art professor of orthopedic surgery. His topic is innovation without limit, AI in a low resource setting. Please welcome.
Okay, I will share my screen now. Welcome to my presentation on how AI can reform orthopedic surgery in low-resource settings. I will explore innovation without limits. These are the outlines of my presentation. I will talk about challenges in low-resource settings, AI in diagnosis and triage, in surgical planning, in teleorthopedics, in training and education, in low resource settings, ethical and practical considerations of AI, and how to address AI challenges in low resource settings. Musculoskeletal diseases are a major issue in under-resourced areas. Let's look at how AI can bridge the gap in orthopedic care. This global map demonstrates the proportion of patients without access to surgery. Nearly 90% of people living in low and middle income countries don't have access to safe and affordable basic surgical care. These are the key challenges faced in delivering orthopedic care in low resource settings. Understanding them helps identify where AI can help. These challenges are lack of infrastructure, limited or unreliable internet access, electricity, and hardware can make deploying or using AI systems difficult. There is often also limited access to large labeled and relevant data sets, especially in local languages or regional contexts. Data might be also incomplete, biased, or not digitized. There may be a shortage of trained personnel who can develop, adapt, or maintain AI systems. Most AI systems are trained in English, making them less effective for local dialects or cultural contexts. Weak regulatory frameworks can make it harder to ensure responsible AI use. There might be also limited public awareness about privacy and data rights. AI projects often start with donor or research funding but lack long-term support or integration into local systems. Challenges regarding orthopedic surgery include shortage of trained orthopedic surgeons, limited diagnostic tools and imaging, little surgical equipment and rehab, besides the geographic and financial barriers. These photos are examples of emergency rooms in Kenya and Gaza. AI tools can analyze basic imaging to assist in diagnosis and triage. As Rowena said a few minutes ago, this empowers general health workers to identify urgent cases. AI supports surgical planning by interpreting scans and creating 3D models, enabling more precise and safer operations. Remote assistance is made possible through AI and augmented reality. This helps specialists guide procedures even from afar. AI-based simulation tools and personalized learning platforms can train local healthcare workers effectively. This is an example of tibial shaft fracture fixation by an intramedullary nail using AI for training young residents. These real-world examples show that AI is already making a difference in orthopedic care across underserved regions. These examples are bone age AI for fracture assessment, AI diagnostics in rural clinics. Development of these examples require, of course, national non-governmental organizations and startup collaborations. When implementing AI, it is essential to consider data privacy, cultural sensitivity, and avoiding bias in algorithms. These are called AI legal and ethical considerations. Organizations are addressing AI challenges in low resource settings through a mix of strategies focused on developing AI models in local languages, building open source datasets that reflect local conditions by the assistance of Google Search, for example, that collaborate with local actors to collect labeled data where none exists. Non-governmental organizations, universities, and companies are training local developers and researchers. There is an example for that, which is Data Science Nigeria, that runs boot camps and competitions to train students in AI and data science. AI is tailored to solve specific community problems such as crop disease detection and maternal health prediction. There is a famous Arman and Google use collaboration in AI to prioritize high-risk maternal care cases via phone-based screening. AI services are developed via SMS or offline mobile apps to bypass connectivity barriers. Collaborations between government, academia, nonprofits, and tech companies help align AI with development goals. This is the Egyptian experience of developing a platform that provide young residents and surgeons with different clinical pathways and protocols to guide them in patient triaging, diagnosis, and management. This platform provides an AI assistant for doctor and a guide application, a website application, and a mobile application also. This to present the vision, making cutting-edge orthopedic care accessible to all through ethical and collaborative AI innovation. To conclude, AI can truly redefine orthopedic care globally. By highlighting inclusive design and access, we can innovate without limits. Success in low-resource settings require community engagement, openness, and long-term support. Thank you very much.
Prof, thank you very, very much. I have to say, this is very personal to me. I do a lot of charity work and visit particularly Middle East countries. May I suggest, the only thing I would probably suggest for your presentation, I think low resource financially, but abundant of resource, brain, intelligence, workforce, somewhere like Egypt, somewhere like India, China, those countries. So with your permission, I will suggest that because I know what type of workforce and what type of sort of expertise those countries have. A blanket low resource can give a wrong impression. Saddened to say, we in Europe as well, and especially in UK, we do share some of your pain with the resources across NHS organizations. It's not unusual to see the picture you show in our A&E corridor. So that I wouldn't be so disheartened if I were you. So we share a lot of that ways, long wait, everything else. Not relevant to, I know these are not relevant to what you've discussed, but my question there, having worked in Middle East and still regularly going there, and other countries in Africa too, main issue I see is the data. Paper-based, sort of disorganized, and sort of some of hospital is not even paper-based, so it's a word-to-word communication between surgeons and the juniors from the ED. Do you not think it's a good start to work on collecting data using AI? Because I guarantee you some of the procedures, some of the, sorry, we're surgeons, so we're pretty much more surgery-based, and that's how our line of communications are. Some of the procedures done in those countries with appropriate data prior to the procedure, you will be amazed what world can learn from the expertise those countries have. I see some pictures from India, unbelievable. Yes. Same with Egypt and other countries, and it's a shame. Do you work on the data pre-procedure and improve on that? And it's a big. Do you not think it's a big opportunity for AI to do that for us? And in fact, we could be a step ahead rather than investing in Microsoft and basic computers. We can jump the queue and go to AI straight, database. Prof. Prof. Imam, did you want to?
Yes, so I think actually it is a very valid point, and I share with Asir what you've. Sorry, I was what I shared. I agree with what you've just said. Sorry, I think it's actually important to use AI sensibly, because a lot of projects I get. I review or serve as an editor has the word machine learning and AI and has nothing to do with AI. So it's a hype. It's a very big word that people are actually using nowadays. But I think actually sensible uses of AI, like what was given by Asir, is great example, and possibly there is a lot of work needed there. I have a question for you, Asir, as well. So what do you think is needed from AI and data scientists to make an impact in low-income countries? And actually nowadays healthcare is under a lot. Every healthcare system have low budgets, but it is very variable, because what we call a low budget in the West might be a huge budget for other countries. So that's the question I wanted to know, because it's actually very important to have, because I think one of the advantages we keep talking about in AI is equality and access to information and data, and how can we optimize patient outcomes everywhere. So what are your thoughts on that?
I think to make a meaningful impact in low and middle income countries, AI must address the real constraints while being culturally and economically appropriate. Based on the practical challenges and opportunities, what is most needed should include offline and low power AI solutions, local language and dialect support. Of course, the point Professor Sarkar raised, which is the data sets. We must work hardly to gather as much data as possible. AI that augment, not replaces local experts. Community-friendly tools for collecting voice, images, and text data. I think also training for the local developers and the government engagement could help in capacity building and AI policy and education. Ultimately, AI must be context-aware, affordable, and empowering. Focused on tools that enhance resilience and not just productivity.
Yeah, I totally agree. And I share what Sarkar has mentioned as well. I think you have the expertise. You have huge number of patients. It is enormous what you see and what you operate on in a lot of. And I share the same thoughts as well myself. We can talk about that for ages. So for timing, we should actually move on. And actually, our next speaker is. An expert in AI, an expert hip and knee surgeon based in Southwest London, Mr. Vipin Asopa, who is going to tell us how AI can help with evidence generation, how can AI help in research, because evidence generation itself is evolving, and I'm sure he will outline it, and AI is playing a huge role nowadays in that.
Thank you very much for the introduction, Professor, chairpersons and colleagues, and thank you for the opportunity to SICOT Pioneer to allow me to be able to communicate my experience in research in orthopedics. I'd like to also thank the various grant supports that I've had and other colleagues that have helped with my research. Research is ultimately an important part of our work in orthopedics. Research is the process of systematically gathering, analyzing, and interpreting information. And it allows us to expand the knowledge base that we have and improve the care of our patients. Advances in technologies such as AI allow more people to participate in research, and this is for the good of society. So there are many steps that are involved in research, and you may know that ultimately research starts by having a question and then generating a hypothesis. Once a hypothesis is generated, the traditional approach was to do a literature review. And that means going to the library, looking up information, or using PubMed more recently. And then that would help us to write protocols, allow us to seek approval, and that could be local and ethical approval to ensure that our study is appropriate and safe. We then need to begin with the process of collecting data. So it depends. If it's a basic science project, that may mean growing cells, analyzing outcomes from studies on the cells. It may include biomechanical studies, for example, looking at cadavers or looking at human activity. And finally, we could be collecting data from the internet now, which is probably the largest repository of data that we collectively have. Once we get this data, which is often now a very large amount, we need to clean the data and analyze it. And traditionally that was done on spreadsheets, and that's becoming increasingly difficult because we can sometimes have problems with the quality of data. The ability to visualize the data is then important to consider. We may want to carry out reviews of the literature in a systematic format before we write a paper. And finally, we need to consider how we manage the references and citations before we submit our research for publication. Sounds like a lot of information, and the steps are quite complex, but they are systematic. And importantly, AI has now given us the tools that can help speed and improve the efficiency of research. The purpose of my presentation is to talk about the points highlighted in red and actually just give a flavor of some of the tools, because we do not have enough time to cover them in detail. And this means that people who can have access to the internet can look at these tools and start considering how they can be involved in research. So the first thing is to generate a hypothesis. A hypothesis is a proposed explanation on the basis of limited evidence, and this forms the starting point for further investigation. So, for example, a question like, what is the best knee replacement, is not a hypothesis, but one might say that a certain type of knee replacement is the best replacement. And that's what a hypothesis is. But there are various tools that can help us to generate hypotheses. So, for example, HyperWrite, Hypothesis Maker, allows you to put a question in, and then it uses a large language model to formulate a hypothesis and tells you why a hypothesis is good. So, for example, in this, it says, based on the literature, I can formulate a more specific and testable hypothesis. And it's provided a hypothesis that is testable. So patients who receive a cemented posterior stabilized knee replacement will demonstrate superior outcomes, etc. Now, we want to often identify what has been published in the literature before we conduct our study. So it's useful to find relevant papers. And also, what would be helpful sometimes is to see if there are connections between papers so that you can identify other factors that may be relevant and help you to produce a very good research project. Two tools that I want to talk about are Semantic Scholar and Research Rabbit. So Semantic Scholar uses machine learning to understand papers. Essentially, it's a bit like PubMed. It allows you to search for information, but then it provides a summary on papers by using a large language model. So it becomes easier to read a paper than going through all the abstracts. Research Rabbit is another tool which is based on looking at citations, but it also identifies connections through relevant papers, and it allows them to form a link. So this screenshot from Research Rabbit shows that from one reference, I found 51 relevant references, which it's listed, and then it produces a map. So it's more visual, so a researcher can look at specific authors quickly. The next step in research is collecting data. Now, data collection is important because we've got larger and larger amounts of data around us. The more that we digitize, and everywhere is digitizing because of its efficiency, the efficiency of digitization and the ability for allowing standardization means that with this large amount of data, accessing it is important. If the data is on an internet or a web server, we can use web scraping tools. But I'm not going to talk about those because that's a separate topic. I'm going to focus on extracting data from documents and data sets that we may have ourselves, such as PDF documents, scanned documents, or spreadsheets. So an potentially important tool that I have come across is something called Extractus. This is a web-based tool that allows you to upload a file and it can extract data out of it. Now, Extractus is an interesting application because it's very powerful, but the problem is that it's web-based, and you have to question where the security or the importance of uploading patient data, for example, and where does it go, and how guaranteed are we about it being protected. So once you've accessed or collected a lot of data and you've got it in a structured format, it's important to refine it because often large data sets have gaps in them and they may not be clean. So there's a tool called Open Refine, which is actually a downloadable open source tool that allows one to analyze their data sets and also match it to other data sets. It allows for cleaning of the data sets and ultimately filling in inconsistencies in your tabular data so that you can then carry out better quality research. Data needs to be visualized, and there are numerous tools to allow visualization of large amounts of data. So Microsoft's Power BI is an example that it has the ability to connect to various different data sources through various computer systems that may be present in our hospitals and around the web and the internet. SciSpace is another tool that is important or helpful in carrying out analysis of literature. And SciSpace allows you to put in a question such as what is the best knee replacement, and it can then provide a summary of reviewed literature. Again, another powerful tool in terms of systematic reviews that can help us quickly get information and plan care for our patients and or outcomes from our research. Once you've got all this evidence and information together and data and you've visualized it, you want to write your article. You've got to consider that if you're using AI tools such as ChatGPT to write your paper, what happens if you upload your paper to the web? Could someone potentially access it? And also, what's the ethics of using AI to write a paper? But ChatGPT shouldn't be seen as a negative thing. It should be seen as a tool. You could ask it for questions on how to improve your communication, how to improve your English. It does have a role in AI writing papers. References can be managed with AI type applications. So Sourcely is another reference management software that can connect to Mendeley, which is used for putting citations into publications. But ultimately, we've looked at all these AI type tools. Are they actually truly AI at the moment? Well, Alan Turing, a famous mathematician and cryptanalyst, said that AI, true AI, is actually the situation where a questioner who poses a question to a human cannot tell the difference when it's posed to a computer and cannot tell the difference between the answers that they give. So ultimately, we haven't quite got there in terms of true AI, but we do have excellent technology which is considered as AI, which is game-changing for research. It allows more people around the world to participate in research and provides for excellent collaboration. But there are many tools that I've not even mentioned which can help with research, and it's important to consider their challenges. So there could be hallucinations, incorrect results, ethics issues, but it's a rapidly evolving environment. And I'd like to just bring to your attention the British Orthopaedic Association's 4th AI meeting in London, where we'll be debating all these topics. Thank you very much.
Thank you very much for such a comprehensive, insightful talk, Mr. Aspoa. It's a pleasure to see that, and actually it reflects how things are changing, because we've done an editorial on AI writing tools, and many of these weren't there. So things change all the time with all these tools. I have a question for you, if that's okay. So what is actually the cut point there? Because I personally think we can have a journal with an AI editor, AI reviewers, and everything can be automated. And I don't think that will take a long time, maybe, before that happens. But then how can we do, what is the balance there?
So we have to remember that actually AI doesn't have the ability to express emotion at the moment, and it doesn't have empathy. And these are very important human characteristics. I'm an associate editor for the NEED Journal AI section. And when I read papers, it's more than just about what's in the paper. It's how it's written, what is it communicating, and what do I want to know as a researcher in AI or AI-based tools. It's important to understand all of those factors and think about them probably outside what AI is able to do at the moment. So I think that at the moment, like previous speakers, AI lacks emotion, it lacks empathy, and those are things that humans can provide. I would see AI as a tool. It's like a blood pressure monitor. We use it to help us improve our quality of work and efficiency and provide equity of research.
Excellent. I totally agree. And one last thing, then, from an author's perspective, in what ways can large language model accelerate systematic review pipelines without compromising transparency? Because that's also another issue. There is a few platforms. We actually helped with developing one as well, where you can do screening and things like that. So with systematic reviews, I think AI is being used a lot more than before now.
I think the importance with these things is you can't trust AI completely. So it's important to have some background knowledge in the topic that you're investigating, and maybe have some experts involved. Do reading around yourself and use for different tools to mitigate the risk of bias, hallucinations, false information. That's the importance. We use tools to help us. We've got to be careful. They may not be entirely accurate at the moment.
Yes, I cannot agree more. And I think that applies to all our tools as well. You know, you can cut a nerve with a saw, and you can do a very good job with a saw as well. So thank you very much for this insightful talk.
Thank you.
Thank you. The next speaker, Professor Sue Turner. So I struggle to introduce her, because I just find nothing more interesting than listening to someone who doesn't just bring AI. He's got a blend of low, then AI, qualified for on both fields. I could probably spend 15 minutes to talk about contributions she has made. So I'm really honored to meet her virtually. I hope I could meet her face to face too. It's summarized it to say she is among the world 100 women. There's a reason they didn't put men. I think she would have just been outnumber all the men in the AI field. So please, Sue, it's your turn.
Thank you. It's an honor to be here, and thank you very much for having me join you today. I'm going to share a few slides and talk to you about a topic which crosses, I think, everything that we've been talking about. We've had wonderful examples about using AI in your field, in education, in research, and we've also touched on some of the issues to consider about AI implementation. And this short presentation will prompt you to think a little bit more about some of the risks and impacts, however you might be using AI, and I'll give you some practical ideas to ensure that you've got good AI governance in your approach to AI too. So we'll look at why AI governance matters and what it is. We'll look at the 8 stages of good AI governance, and I'll share with you the responsible AI framework that I use with my clients. Who am I? Well, I'm chair and non-executive director of various companies. I'm also a professor of AI in practice at the University of Bristol. And my background is not technology. I came to this route originally through law, and then most of my career has been spent working with dynamic entrepreneurial businesses and also with not-for-profits in roles like chief executive, director of communications, and so on. So nothing to do with technology. But I recognized, 10 years ago now, that data and artificial intelligence are really shifting power in our world, shifting power away from regular people and into the hands of a tiny number of people and organizations. And there's a woman called Rachel Colcott who put this brilliantly when she said, we need to make sure that AI benefits 8 billion people, not just 8 billionaires. And that motivated me to do a master's degree in AI and data science and to set up the company AI Governance that I run, which has the mission to inspire as many people as possible, that's all of you, to use AI with wisdom and integrity. Now, when I work with leaders in the healthcare sector, that's whether it's in the National Health Service here in the UK, with private healthcare providers around the world and related businesses like insurance companies, we're often needing to develop the skills and confidence that leaders have around AI. Now, many leaders and managers are pretty new to being digital leaders, so I thought this list of characteristics of digital leaders might be helpful to people to see. It's one that's been used quite widely. You may have seen it already. But I think it just highlights how daunting it can be for non-technical people or people who've got a specialism in a field like you have to grasp all of these different elements all at the same time. So that's really the first thing to recognize. Many leaders feel out of their depth when dealing with artificial intelligence. And then when we layer on top questions about how we govern AI, it can make people feel overwhelmed. And often I see them being tempted to say they'll deal with the issues of governance later because there's just too much on their plate. But it's a really bad idea to put governance secondary, to put it further down the line, because there are impacts we need to build in right from the start. So why does AI governance matter? Well, normally we'd get legislation, we'd get regulation in most parts of the globe that would push us towards taking certain actions when we use a tool or not taking them. And we're familiar with that, aren't we? With things like product safety, data protection that's already been mentioned. These are things where we're given guidance from the top, from our governance, from our various regulators, so we know what we should and shouldn't do. When it comes to artificial intelligence, of course, those same rules still apply, but there are many other areas where we could use AI, but we're not given the guidance to know whether we should or we shouldn't. So we're seeing very innovative tech companies, for example, giving no guardrails, no guidance to their employees in how they might develop artificial intelligence, which you could end up using. Here's an example from my own experience. I was approached by a data scientist who had been given some data to work within his organization, and he put together different data sets to predict who amongst the technical people in the organization, who was most likely to leave the business. Now, he found that he could find a pattern in people who'd left in the past, so he could make a projection as to who might leave in the future. And that meant that the line managers could target advice, could target activity to those people who were most likely to leave. So the data scientist approached me because he said, I've no idea if I should be doing this or not. My bosses don't understand what I'm doing. They don't understand how it works. They're just not guiding me. So we often see this. A lack of governance structure doesn't help people to foresee the issues, and it doesn't give clear guidance. Here's another example. DeepMind, the very high-tech company owned now by Google, they've moved recently from publishing lots and lots of their research very openly, and now they're keeping more hidden. I understand that's because they want to protect their competitive edge, but previously when they were publishing lots of research, it was enriching the world, helping people to understand things. Now they've got a different stance, and deliberately so, but perhaps that's not the best that they could do for impact on society. Here's another example from financial services. One bank I've done some work with, they started off by having an AI ethics committee. Now, in the healthcare world, you're used to having ethics committees, but this was an AI ethics committee, and all the different use cases for AI in the bank came into that committee. They then discussed them and then made decisions about what should and shouldn't happen and made recommendations to the board. Over time, though, this method didn't work because the committee would meet once a month and there were so many different ideas for using AI coming forward that it just couldn't look at them all in good time. What they've decided to do now is to diffuse responsibility for AI governance through the organisation. So there's lots of places, lots of different teams that can decide whether to go ahead with different AI uses or not, which is faster, so they got over that problem. But now they've got another problem. They lack consistency because different teams will take different decisions. The truth is that most organisations don't have a clear approach yet to how they are governing their use of AI. Most are still in the footholes, working out how to harness the power of AI, and they think they can do the governance bit later. But if we don't figure it out early on, then we start to be very invested in wanting to use AI in particular ways, and it's hard then for us to go back when we realise that perhaps we're causing some harm by our use of AI or could do things better. So let's look at the 8 stages in good AI governance. You want to make sure your organisation's got a really solid process and approach in all these different areas. First of all, you've got commitment. You need to select what's known as a responsible AI framework and commit to using it with each AI use in the organisation and across all your different AI uses. I'll show you in a minute what a responsible AI framework looks like. There are many out there. The OECD has produced one. Companies like Microsoft and Google have all produced them. So you have to find the one that fits your organisation and your needs best. I'll show you one in a minute. Secondly, there's looking at having an inventory in the organisation. Many organisations are getting AI, either developing it themselves or buying it in tools from third parties, and they have no idea that AI is in those tools, and they certainly aren't keeping an inventory of what there is and how it works. At some point in the future, we'll have many more standards for AI, and we'll need to have that inventory to know where AI is in our organisations, what it does, and how we're controlling it. And this means we probably need to change our procurement practices so that people leading procurement in our organisations ask questions about where AI is so it doesn't sneak in unnoticed. The third part of good governance of AI is stakeholders. We need to decide who our stakeholders are, what their interests are, and get them involved in the decisions about how we will and won't use AI. Tied in with that is communication. You need to strive to be clear about how you're making decisions on where you use AI and educate and communicate internally in your organisation as well as to external stakeholders. That's really important to do to build trust in how we're using these tools. Next is controls. Can we be sure that we're able to identify and mitigate potential risks of using AI? How will we know that we're controlling it well? 6, of course, is security. We're all very aware of cybersecurity issues. Artificial intelligence can bring in new risks. So is our IT security, our cyber processes up to date when we're thinking about those risks? Second to the last, we have regulations. Are we scanning the horizon regularly to look for changes in regulation and legislation in our environment? And then last but not least, evaluation. We need to be responsible for monitoring the performance of our AI, and that means we've got to establish some clear metrics and assess the AI tools against them on a regular basis. Now, I said I'd talk about responsible AI. This is a responsible AI framework that I've developed and use in my organisation. Now, whether your organisation's well on the pathway of using AI or you're just starting to think about it, now is the time to get straight on how you're making ethical choices about using AI. And this responsible AI framework helps you to do exactly that. The first area is accountability. Who in the organisation will make the ethical choices? Who should decide whether to allow AI to replace some human workers or only enhance their work? Is it the boss of your organisation? Is it a committee? Is it involving lots of stakeholders? Those are decisions you need to make very early on. You could, for example, use AI computer vision as part of the process of hiring people to come in your team. But some people might struggle to interact with that technology, so they're put at a disadvantage. So who's going to decide whether or not you use AI in that way and many other ways? Then there's human agency. Where are we fully automating processes using AI, and where are we keeping humans in the loop or on having oversight of our systems? Recently, the media reported on a person who'd been recruited into the UK's civil service without ever speaking to a human. It was all done by computer vision interviews, staring at a computer and a camera like this. Did anyone in the organisation, in the civil service, make the decision about the ethics of this? In my view, it shifts far too much power to the hiring organisation by denying the job candidate the opportunity to ask questions and interact freely with people to find out if he really wanted to work there. Next is robustness and resilience. Will the model change over time? How can you be sure that it's going to still do what you expect it to do when new data gets fed into it? And the cybersecurity issues that I mentioned earlier matter too. I won't dwell on data governance and privacy. We've touched on that earlier in the presentations, but incredibly important to make sure that you have consent to use the personal data and sensitive data in this particular application and not just generally in your work. Then there's transparency and explainability. Transparency means that we're being clear with people about when they're interacting with AI technology. Do we pretend they're getting help from a person, or are we honest with them that it's actually a bot that they're interacting with? And explainability means being able to explain how the AI tool works. Now, many deep learning models and generative AI tools find patterns that are hidden so deep that they simply can't explain to us how they work. So if it's important in your work to be able to explain to a patient, for example, how a decision's been made, then perhaps you need to use a simpler AI model, even if it might be less accurate. And then we've got diversity, non-discrimination and fairness. This brings up a huge amount of issues that we've touched on in presentations earlier on. We know, for example, that historical data in healthcare is not unbiased. We often have more data about men's symptoms, for example, for some conditions than women's, or data on some races and not so much on other. So when we build an AI model with this statistically biased data, that will be reflected in the model, and it could lead to unfair outcomes. So it's really vital that we understand the data, how the models are built, and that we're checking for those statistical and social biases. And finally, with responsible AI, we need to look at the societal and environmental impacts. Lots of organisations talk about taking a digital-first approach, which sounds very modern, but will people who have less access to technology be disadvantaged? As we heard from Professor Sallam, AI has a significant part to play in low resource settings, so that needs to be built into the way we design tools and systems from the start. And of course, we must mention the environmental costs, the water and the energy that it takes to train AI models and use models that are trained by others. How do we factor that into our thinking? So to conclude, however you're planning to use artificial intelligence, however you might be using it already, whether it's developed by your organisation or bought in from a third party, make sure that you have discussions about AI governance from the outset and that you regularly review them as the technology and its uses change. Thank you.
Thank you very much for such a very comprehensive talk and lecture. So it's a pleasure to have you on board, and I know you have a very busy time schedule. So, Sarada, any questions for Professor Turner?
Thank you very much. One thing I've always wondered, we as a clinician tend to publish paper which basically concentrate on positive outcome. I've asked a number of colleagues throughout I've been consulted only for a few years. There seems to be anxiety regarding litigations in the long term. See, when AI comes, that probably suddenly adds slightly more anxiety because of the excellent sort of item you mentioned. How can we, as a clinician, be protected to be encouraged to actually publish paper which has got negative outcomes, which we're not as great as we think based on our literature? That was my first question. And the governance, there is no consistency between two neighboring trusts. Where exactly the problem is? Because that has created a lot of issue for us.
Yeah, gosh, there's a whole lot of subjects there. And yes, Professor Imam, thank you so much for having me along onto this session. It's very kind of you. So in terms of protecting yourselves as researchers and as practitioners, I think it's inevitable that there will be lots of litigation around this area in the future. And the best we can do without that regulatory framework that tells us what we should and shouldn't do is use our best endeavours. And I think this is where the healthcare sector has an advantage over other sectors using AI, because you are used to working with ethics committees. You are used to having those discussions and frameworks. So I think you're a step ahead of many other sectors in the world, because you can use those same frameworks to push ahead and say, well, we are going to at least have a group of people who are looking at our particular AI use case, who are looking at our particular research and giving a view back on, are we causing harm? What might we need to consider? Where might liability lie? I didn't mention it in the presentation, but the European Union has recently produced the EU AI Act, which does give guidance on different risks levels of different types of AI and different procedures and processes to put in place depending on how risky the AI use is. The EU were also going to bring forward an AI liability directive, and that would have given a much clearer framework for organisations outside the EU to adopt and use. But unfortunately, this year, they've cancelled that work. So it's really disappointing. It would have been very useful for work to have. In terms of data standardization across different trusts, for example, standardization of way of using tools, whether that's in the UK or between different countries, there's huge amounts of work to do there. I do quite a bit of work with the United Nations, a part of the UN called the Information Technology Union, which isn't a trades union. It's a body that is responsible for our mobile phones working wherever we take them in the world. So they've got a really good track record of doing complex work behind the scenes to get that interoperability, whether it's of data or of systems. There's a massive journey to go on with AI and that sort of interoperability, but I'm quietly confident that the UN structures are well placed to be doing that work. I think there's too much of their time at the moment perhaps being taken up with some other issues. Necessarily, things like AI safety, the existential risk questions are huge, and just not enough resource to be able to do everything. But I'll keep pushing, and we'll keep trying to get more work on and progress on that field.
Thank you.
Thank you very much. Thank you. We appreciate your attendance with us, Professor Turner, today. And now we move to our final lectures, which links data to real-world outcomes by Professor Ashish Gupta from Brisbane, Australia. He's an eminent shoulder surgeon, scientist, researcher with a lot of expertise in digital health. And I'm looking forward to hear his talk. And we're very grateful because I know he did a lot of traveling today, and it's night time now there. So thank you for attending and for being with us, Ashish.
Mo, thank you. Can you hear me?
Yes.
I've been listening. It's been quite a fascinating last 1 hour. So it's like a pig in mud. I'm just going to share my screen. Can you see?
Yes.
Awesome. So I've spent the better part of my last decade of my life figuring out how we can use machine learning and data analytics into our clinical practice. So going away from the theoretical belief as to what needs to be done and the ethics and the clinical governance and the technology which we have, my journey has been in how we can converge clinical research, basic science research, and clinical practice into something which we can use it day to day in our lives. And that's led to the journey and inception and now the formation of Akuna, which is our company, which is present in over 25 countries in the world, where we're providing data analytics and AI solutions to surgeons globally. These are my disclosures for this talk. The main one is that I'm a CEO of Akuna. So what is artificial intelligence? And is this something which is a pie in the sky, or is there something which we can use artificial intelligence in? And this is our planning software, which is called Reflect, which is for shoulder arthroplasty and trauma. And this was the first AI-generated or AI tool-enabled planning software which got FDA approval. And basically, a click of a button, this is what artificial intelligence does. The artificial intelligence in this scenario tells us with significant glenoid defect what should the premorbid shape of the glenoid or the humerus should be. This then enables us to ascertain what the reconstructive options are. In this case, I've planned to do a allograft, and then we've converted this from a plan to bespoke custom allograft measurements, and then executed this in surgery. This paper has been published as well for those who are interested to figure out how custom allografts do. And then this is the reconstruction postoperatively of the patient with CT segmentation, because we've got the tech to do metal artifact reduction technology, which is powered further by machine learning tools. So anybody who's bored, we did a comprehensive paper on deep learning in orthopedics, its applications. It's 65 pages. It's published in a very high-ranked journal. Anyone who's interested can read this, and I can assure you you'll fall asleep very quickly. One of the key things which was alluded to during the last hour is just because of its artificial intelligence, that doesn't mean it's right. I firmly believe garbage in equals garbage out. And in Australia, we say you can't make chicken pie out of chicken shit. So the most important thing about artificial intelligence is that just because it's machine learning, we have to put a lot of effort into what's trustworthiness of this AI model. And we put a lot of effort in our team here to delineate what is trustworthiness. And essentially the three factors which ascertain trustworthiness is that there should be trust in the model which is being generated. There should be trust in the data which is input to create the models. And then the processes need to be trustworthy. And there's a fair bit of work which is, as I said, our team has done in this domain. But the key to me and the key to most of us is, what good is AI if I cannot use it in a 50-patient outpatient clinic? You know, it's great for research, it's great for things here and there, but how is it going to intersect what happens in clinical practice? The main question then comes is, why should I pay for this software? And is it actually another software tool which is adding to my workload? And does the computer actually know better than my 20 years of experience, which most of us as surgeons would say? Does it improve my results? Does it grow my practice? And more importantly, for a lot of us in private practice, is it actually generating us money? So when I posed this question to my team of techies in Akuna, they said, you're basically searching for God in a box. And then this thing came along and we were like, hallelujah. And, you know, we incorporated ChatGPT into our database in the Akuna platform. And I thought once we get all our data incorporated and we look at stuff, we looked at the identified data for ethics and transparency purposes. And basically, this is the answer it gave us. I wanted to know what the outcomes of my rotator cuff repair are, and it is talking to me like a politician. This is not something which I can use as a surgeon. This is not something which helps improve my practice. This is definitely not something which gives the patient any confidence that they want to have an operation by me. And I was like, really? You know, you spend all of this money and you have so many parameters and you still can't give us an answer. So we went back to the drawing board. And then we said, let's figure out something which we can actually use. So then we developed our own natural learning tool, which is called Akuna Insight, which trolls through my database. And I've asked the same question, and it gives me real-time data and real-time feedback as to what the answers needs to be based on all my clinical questions and governance. So the most important thing in this is, as has been alluded to before as well, is analyzing your data is important, but that data is only as good as the amount of data you put into the system. And most important thing is the journey as to how robustly you collect data and if you've got complete data and how honest we are with this data collection process. The problem in medicine is data is disconnected. You can Google anything and you will get a lot of answers. But when it comes to your medical data, they're all siloed within these guises of cybersecurity and patient confidentiality, which I personally think is all BS. And they're all sitting in these EMRs, which we can't really query and we have no way of looking into. My health data is like my money, and I should be able to look at my health data and carry it across the world wherever I go. I do not think it is the responsibility per se of any government organization or private hospital or insurance company to control of all of my health data, and I do not have access to it. And that's what EMRs do. For data to work, we need to convert it from this junk into something which is classified and categorized and tagged. And only once it's classified and categorized and tagged, we can analyze this in a sensible fashion. So this journey started for me 10 years ago, and I started with Google Forms and Excel spreadsheets and paper forms, and that's led to the inception of Akuna and basically getting validated data in a format where patients can enter this within 5 to 7 minutes, which is based on ethical guidelines and guidelines for due consent, which adhere to the GDPR and the HIPAA guidelines, where the consent is a critical process of how data is given and data is shared and data is extracted between the clinician, the healthcare providers, and the patients. And what this does is then it's basically a data aggregator which aggregates data from multiple different sources, categorizes it, tags it, classifies it, organizes it based on organizational frameworks, due governance, and cybersecurity, so that the data is handled carefully, de-identified in cases of trials, and there is a due consent from the patient and clinician when this data is shared. So in the clinic, while the patient is waiting outside, they get an iPad and they filter out and they put all their data in. In the clinical examination, I or my fellows or the physiotherapists, if it's done on an outreach setup, do a standardized clinical exam, which is excellent for clinical teaching and registrar training, because then they have a cookie cutter solution which everybody has to follow. The imaging gets incorporated into it, and we've built quite a few models in terms of auto-segmentation of MRIs, auto-segmentation of CT scans, etc., etc. And then the planning software incorporates all of these other factors, which further adds to this data collection. We built a very comprehensive revision platform for revision surgery, which allows us to do single-stage revisions. So all of this comes together. And then one of the key things which we've done is we've incorporated a lot of the data which is collected from the operative notes. Now, a meniscal tear with an ACL is going to have a completely different outcome compared to just an ACL alone. A degenerative rotator cuff tear is going to have a different outcome compared to an acute robust rotator cuff tear. So what the quality of the tissue and what the surgical procedure happens during the operation, as we all know, has a very significant correlation with what the outcome of the patient is. So collecting intraoperative data is very critical in this pathway of journey, and not just scribbling some notes, which we all do for the standard operative notes, which are often linked to medical legal requirements. And then once all of this is done, the patient goes and has a copy of all of this data on their platform, and wherever the patient goes, whether they go to their GP or they go to a physio or they go to a different hospital or a rehab facility, they carry this data with them, and anybody who intersects this patient at any point of time then adds that same minimum amount of data which is required to get this outcome. And then all of this is then put together, and this results in what we call Akuna Insight, which is our machine learning tool for data analytics. And then this will help us give predictive analytics. So this is what I do. I've got over 10,000 patients in my practice now, which we have complete data. And if I ask them a question and I sit in front of my patient and I say, well, we're going to be booked for a reverse shoulder replacement, and I show them this is the outcome of my patients, so my last 1,000 patients I've done a reverse shoulder replacement on. If we want to go further and compare one technique versus the other, so I'll say, show me the prompts for anything. You can search anything in orthopedics for this based on whatever data you put in. And we want to look at cemented humeri versus uncemented humeri. It'll give me that data as well. So what this is doing is it's scanning through my database, giving the patients the outcome from my data. If you have an organizational setup, you can look at it within your organization. You can compare this to global data, which is de-identified. And so this gives you a lot of trust in what your practice is and gives the patient a lot of trust on how you're doing. The platform is now in over 25 languages. It's right to left and left to right. So it fits Arabic and Hebrew and Japanese and Chinese, because one of the key things for us is that we need to get the data, the prompts from the patient in their own language. We connect with the patients in the form of a messaging and video conferencing facility. And one of the key things which we've been able to incorporate in this is, why would a patient fill out a survey? You and I know that when someone asks us to fill out a survey, we never fill out a survey. And so there has to be a carrot for the patient. And the carrot in our in our experience has been education. So we have built a whole medical education platform for the patient. And this is called Akuna Med. So there is a public platform for the patient and a public platform for surgeons, which is a bit like ViewMedi for doctors. And then we have our own channels for registrar and fellow teaching and departmental teaching. And this has been the carrot where if we ask the patient to fill in the survey, they get all their physiotherapy prompts and they go step by step and then they fill out their survey. So, why should I pay for it? We don't. The outpatient model is built into this. Most hospital groups have built this into their workforce. Is it adding time to my workforce? And the answer to that is not. It's actually reducing my time to the workforce so that the 10 minutes or 20 minutes or an hour I spend with the patient, I'm actually spending them knowing them better and making a decision rather than just looking at a computer and jotting notes down. Does the computer know better than me? The answer to that is no, it doesn't know better than me, but it helps me make a better decision, and it probably many a times reaffirms what I'm thinking. It does improve my results in my hands, and it has grown my practice, which indirectly does make me more money and give me autonomy. So I'll give an example of an anatomic reverse. This is a concept which I've populated a lot globally, where I believe that we need to restore the joint line and we only lateralize as much as we need it. I think there is this massive global trend of excessive lateralization, which causes nerve palsies and a whole bunch of problems. I don't believe in this inlay concept. I think the humerus needs to go where it needs to go for an individual patient. And if the joint is too tight, we inlay it. If the joint's too loose, we onlay it. Then we impaction bone graft the humerus to look at what the proximal humeral bone is and reduce the filling ratio so that we don't have stress shielding. And this concept, we wanted to test this concept and look at my registry in the group of patients where with a new implant, because I was using Tonier prior and then I converted from Tonier to using Medacta. I saw that Mo was using the NextAR with Medacta as well. And I just wanted to look at my last 100 or so cases done in a year to see what the outcome for this patient is. And I was very rapidly with this, the company people came and some of the students came and they were asking me, you've converted your implant, what's your outcome? And we were able to, just with the touch of a button, be able to give out all of these scores immediately. So you could look at the constant scores, the ACS, SST, you could look at the range of motion, external rotation, etc., etc. The sky is the limit. This was the data which was generated by the platform automatically. You did not need a research assistant or a statistician to generate this data. And it gave me a lot of confidence to see that despite changing my implant to a new company, but still adhering to the anatomic RSA model, I was still able to achieve quite satisfactory results. So I strongly believe that to get on this artificial intelligence journey, we need a software, we need a system in which data is collected robustly. We need a system where ethics and clinical governance is maintained. And our aim with Akuna is to basically bring this to the world in a form in which the surgeons and the clinicians can use and get going in this journey with artificial intelligence. Thank you.
Thank you very much. Very impressive as usual, and I think a lot of work happens there, and a lot of interesting things that I can see definitely. So, I just have one question for you, Ashish. We have a lot of national joint registries, which I think needs a lot. It's a waste. It's a big resource which is not done properly. And we have it in the UK, you have in Australia, it is in Canada, different places. How can you ensure interoperability between an AI-enabled registry like Akuna and existing national joint registries? Is there a way of collaborating both together?
It's an excellent question, Mo. So Akuna is like a 5-year-old kid who wants to go to everybody's birthday party, okay? The problem with the non-joint registries are they, in my experience, they're excellent sources of data, but they're completely entrenched in these cobwebs of governance and politics and bureaucracies, which are often very hard to penetrate. So I have the ability that the data which I'm collecting is on the same principles as what the data requirement for the Australian and the UK joint registries are, and I can export my data directly to the joint registries. In places like India, Akuna is partnering with the Shoulder Elbow Society there, and we're talking to the Arthroplasty Society there to build their joint registry. Okay. So I don't know if Egypt has a joint registry, or Poland, for example, has shown very keen interest to build a joint registry now. So I think the future will show in terms of the collaboration which we can have with the well-established joint registries. But my endeavor with Akuna is to democratize healthcare and provide tools to the developing world and the world at large, which do not have the frameworks and the setups to build these joint registries, to enable them to start getting there on this journey.
No, excellent. I think it's a lot of work, and it is the future for sure. It's the present, not the future for sure. And thank you very much for such a comprehensive presentation, and a lot to learn and possibly. And I'm actually to conclude today's program on behalf of SICOT-BOSTAA and chairs, and I would like to thank all the speakers and participants, and hope a recording will be circulated and certificates will follow automatically. And this is you can also get a personalized certificate. I'm very grateful to our eminent talkers and to my co-moderator, Mr. Rada, for sharing this with me, and I've learned a lot myself, and it's very and I think this should be a start of a lot of collaborative projects in different aspects of digital health. Thank you all.
Thank you.
Thank you.
Thank
and
you.
Sorry, Ashish, for keeping you waiting, and to